So I realize I'm the speaker between you and the beer. But I have some new data. I think it's an issue that comes up all the time in management of patients with advanced disease. And I'll get through it as quickly as I can. I retell that testosterone matters, and you'll see why. It matters in the off-treatment interval in terms of quality of life. It also matters in the on-treatment interval. So some disclosures. I've been very involved in this field of hormonal therapy. And in fact, the story of intermittent therapy for me is now about a 25-year journey, because the first paper on intermittent therapy was a paper that I wrote, Willett Whitmore's patients, 20 patients on diethylstilbestrol in the pre-PSA era with metastatic disease. Probably the first patient on intermittent therapy was Bobby Riggs, the tennis player. Whitmore's patient, had metastatic prostate cancer, eventually killed him, couldn't compete on estrogen and begged to come off. And the rest is history. So we had those 20 patients, and then around the same time, Nick Brukowski, a molecular endocrinologist in Vancouver, proposed this counterintuitive hypothesis that re-exposure of stem cells to androgen would reinduce the apoptotic potential, might actually have a potential benefit in terms of long-term response. And then there's been a whole slew of data since then. So that's our first study, 1986, showing that you could cycle patients. This had never been done before. On and off treatment, they'd continue to respond. It was clinical assessment. So when the pain came back, they'd go back on diethylstilbestrol. And it led to, and this is Nick's study showing in the Shionogi androgen-dependent mammary model, that by transplanting the tumor into intact mice, castrating them when the cancer grew up, you could actually double the duration of androgen dependency, although it's 5 animals rather than 1. So there's a lot of controversy about that model, but at least clinically it led to a whole slew of phase 2 trials, mostly retrospective, mostly small, mostly not that much follow-up, but showed that, during the off-treatment interval, quality of life improved. Patients would continue to respond with serial cycles. The cycle length tended to get shorter over time. I was part of one large one led by Nick Brukowski in Canada, more than 100 patients. And we learned a lot from that about the biochemical response to treatment, how long it took to reach a nadir. And there was also a series of prospective randomized trials that are listed here. And these were mostly a mixture of patients, metastatic and non-metastatic. And the key ones were the Portuguese trial here of 900 patients. Again, mixed population, no difference in survival. A lot of them were kind of inconclusive. And so the kind of jury was out in terms of the key question, which was, does intermittent therapy offer the same survival, both prostate cancer and overall survival, as continuous therapy? And then about a year and a half ago, these 2 studies were published within a few months of each other, New England Journal. The Canadian-led study, which I was the PI on, the PR7 in non-metastatic prostate cancer, rising PSA after local treatment, and the SWOG 9346 in patient with bone metastases. And these were kind of companion studies. Canada helped SWOG with accrual, and SWOG and the UK participated in the Canadian trial. So just to run through these briefly, the PR7 non-metastatic trial, 1,400 patients approximately. Patients in the continuous arm got lifelong LHRH plus anti-androgen for a month to block flare. In the intermittent, they got 8 months of treatment. It takes that long to reach PSA nadir in the average patient, and then came off therapy and were restarted when the PSA rose to approximately 10. The PSA had to be above 3 for them to be eligible. They had to have a negative bone scan, continuous therapy when they became androgen independent. And basically, this trial's gotten a fair bit of attention. Absolutely no difference in overall survival. these were both non-inferiority designs. That is a trial design that has some complexities that most people don't understand, and it becomes relevant. I'll come back to that in a minute. But the p-value is highly significant for non-inferiority. So this is kind of a reversal of the usual. Usually you look at that and say, oh, the p-value must be very high. There's no difference. For non-inferiority, you reverse it. So it's very high likelihood that there is non-inferiority in terms of overall survival. And there was, I'm going through this at a very sort of sky-high level, but the other key point is the bottom two lines are the prostate cancer mortality. About a third of the patients who died of prostate cancer, about 2/3 died of other causes, which is, I think, one key message about PSA failure. You usually die of other causes. But there was a trend to more prostate cancer deaths in the intermittent arm, the pink compared to the yellow. And there was the same number of non-prostate cancer deaths increased in the continuous compared to the intermittent. Canceled each other out. In any case, the difference did not reach significance, p.24, in terms of disease-specific mortality. So this trial was resoundingly negative in terms of showing no difference between intermittent continuous therapy in non-metastatic cancer. And this is stratified by grade, so there was a trend to better outcome in the higher grade with continuous, and a little better outcome in the Gleason 7s with intermittent. Again, not statistically significant. You can't make too much out of that. And there was some quality of life improvements in the off-treatment interval. Pretty much in every domain, the patients had an improved quality of life. And just to show what happens, that the cycle length, the first off-treatment interval was approaching 2 years, 20 months on average, and then it gets shorter over time as the patients start to become hormone refractory. So that's the PR7, non-metastatic. And then the story got a little more complex with this metastatic study, 9346, also a large-scale study with long follow-up. This study was started earlier. It took almost 20 years to accrue and report. 9346, so the 93 means it started in 1993, reported last year. Also about 1,400 patients. Gleason and biclutamide, somewhat different design. Because these patients had more advanced disease, metastatic, higher PSA on average, they were only randomized if the PSA dropped below 4. Again, this was designed 20 years ago. Today we would say a PSA of 3 to 4 on hormones, not very good. But they were randomized if the PSA fell below 4 to continuous versus intermittent. Overall, cause-specific survival, quality of life were the primary endpoints. Reinitiated treatment when the PSA was above 20, so slightly different approach. No one knows whether 10 or 20 is the right threshold. And here are the results of that trial. So you can see there's a little bit of separation of the curves favoring continuous therapy, hazard ratio 1.09, and there is the confidence limits 0.95 to 1.24. In other words, not a significant difference. There was a retrospective stratification of the outcome according to minimal versus extensive disease, which was really defined as location more than number of metastases. For what that's worth, that's how they did it. And, that where a difference, somewhat of a difference emerged. So in the minimal disease group, which was disease confined to spine, pelvis, and or lymph nodes, there was the hazard ratio 1.23 favoring continuous, with the advanced extensive metastatic disease, no difference at all, hazard ratio 0.96, if anything, favoring intermittence. And some quality of life benefits. I won't go into that in too much detail, but patients, if you use intermittent therapy, you know patients definitely feel better off treatment. So when this study was presented by Maha Hussein at SWOG, she said, intermittent therapy is inferior to continuous for patients with metastatic prostate cancer. And that created somewhat of a firestorm because that is actually not what the data showed. And this is from the ultimate publication, which is in New England Journal. For those of you who are interested in how to communicate results, read the discussion in that paper because it becomes crystal clear the authors think intermittent therapy is worse. The editors wouldn't allow them to say it because actually that's not what the data showed, and they turned somersaults trying to express in between the lines, we really don't like it, but unfortunately the data didn't confirm our preconceptions. The findings were statistically inconclusive, that's what the paper says. The confidence interval survival exceeded the upper boundary for non-inferiority, cannot rule out a 20% greater risk of death in intermittent therapy, but too few events occurred to rule out significant inferiority. Well, you never know. If you know anything about statistics, you can't say it's too few events because you don't know what those events are going to be. Improved quality of life. For the biostatisticians in the room, the amateurs, this is a great paper called How to Interpret Non-Inferiority Trials. And it was actually updated in, I think, 2011 in JAMA. And this comes from that paper. And it shows that when you do a non-inferiority trial, you set a delta, which is what you think is the clinically significant difference that you want to rule out exists. And to show non-inferiority, you need this. You need or to show inferiority, you need both ends of the confidence limits beyond the delta there. Here's where we were with our non-metastatic trial, non-inferior. Here is where the SWOG trial is inconclusive. And there's absolutely no question you cannot say anything other than it's inconclusive based on this fundamental methodologic approach. And you also can't rule out superiority. Unfortunately, you just can't say much. A trial of 1,400 patients that took 20 years to do. And then just to reinforce that message, this was an overview of the whole topic by some heavy hitters in JCO, Ian Tannock, et cetera. Here is overall survival, time to progression, prostate cancer survival, all of it crossing unity, therefore no apparent difference in survival. So I think the conclusion of this, just to cut to the chase, is for non-metastatic patients, really there is no reason not to use intermittent therapy. For metastatic patients, there's a bit of a question. Maybe in some patients it's not as good. Practically speaking, you stop therapy for you select the patients who have an excellent PSA response with a fall of PSA to undetectable levels, not below 4, but to undetectable. In those patients, a trial of discontinuing therapy is essentially risk-free. Some of these metastatic patients will remain off treatment for years and have clearly had some benefit. In the ones who don't have a good PSA response or who have a short off treatment interval, you just continue with continuous therapy. So that's the background to the point I really want to make, which has to do with the serum testosterone. So for those of you who are familiar with this field, there's been a tremendous wave of enthusiasm over the last, I would say, 5 years or so about serum testosterone on hormone therapy. And there's really 2 studies out there that show that you have to drive the testosterone as low as you can to get the best effect in terms of prostate cancer suppression. And that is a challenge to supporters of the intermittent therapy concept because the testosterone comes up during the off-treatment interval. So there's a conundrum. The evidence that low levels of testosterone is associated with improved response and survival, and yet intermittent therapy seems to be essentially equivalent to continuous therapy where the testosterone comes up. And I've been at least a dozen meetings where someone has asked this question and everyone just sits there saying, I don't know, doesn't make sense. So I think we now have some data to move that forward. So here are these 2 studies, One is by Moroti, one is by Parashino. Excuse my language. They're both crap. This one is 79 patients, I believe. Retrospective. Patients with a combination of non-metastatic and metastatic disease, treated with ADT, time to androgen-independent progression stratified by testosterone. I think we use the nanomolars per liter, which is 0.7 to 1.7, and above 1.7, which I think is also European. You use nanomolars? 1.7? So the conversion factor is 28. I'll stick with nanomolars. So you can see there's a big difference in outcome. Remarkable difference in outcome depending on how low the testosterone is on hormonal therapy. But it's a retrospective study of less than 80 patients. And the other one is Parashino, 129, at least a little bigger. Testosterone is predictive as PSA in survival in men on hormonal therapy. You know, PSA is very predictive. But this always bothered me because these two studies were quoted over and over and over again. And I thought this is the basis for this entire edifice of marketing and promotion and aggressively insisting that low testosterone was important. And you had, on the other hand, the intermittent therapy story where the testosterone comes up. It doesn't seem to make a big difference. Plus, we know that the mechanism of androgen-independent progression is intracrine synthesis of androgens. So how could it be so critical to drive the testosterone low when the cells are creating their own androgen as they become androgen resistant? So I was skeptical. We know that failure to reach those low levels of testosterone is common. So about a third of patients on LHRH agonists will fail to consistently have testosterone below the 0.7. So I had this idea. We had these patients on our non-metastatic intermittent trial. Half of the patients, about 700 of them, were on continuous hormonal therapy. We collected testosterone every 3 months on those patients, essentially for the duration of the trial. So we've got long follow-up on 700 patients on continuous hormonal therapy with testosterone. And this is such dramatically more reliable data than a small retrospective series. So here's what we found. First of all, this is the breakdown of the testosterone in the first year of continuous therapy. So about half of the patients had a median testosterone that failed to fall below 0.7. This is consistent with what others have reported. And a 5% never even dropped, had a median above 1.7. And if you look at the maximum, it's very common for patients to have a serum T, which was taken just before they got their injection each time. 75% at some point popped up above 1.7. And here's the data, which, to my amazement, confirmed the results of those two studies that I had dismissed all those years, that in fact the serum testosterone had a major impact on time to androgen-independent progression. Hazard ratio of almost 2 for the ones whose median, this is the median testosterone, failed to drop below 1.7, and 1.4 hazard ratio for the intermediate group. And minimum, even more powerful, that means the relatively small number of patients whose testosterone was not suppressed below 1.7 at all, the hazard ratio of almost 3 for time to androgen-independent progression. A little less compelling for the maximum. So maybe this means the mini flare or the surge doesn't make that much of a difference. What's more important is having relatively consistently sustained levels below that threshold, although there was a trend that was consistent with the other findings. So here was this now solid data, and this is brand new data, by the way, just hot off the press, not even off the press, off the, not published yet, but showing that the level of testosterone actually matters. You've got to measure testosterone. If it doesn't drop, you should do something to drop it further below that 0.7 threshold. And then the final point I want to address is how do you reconcile that with intermittent therapy, where the testosterone rises? So here's my proposal. You have the key point is that in prostate cancer, there is a heterogeneous response to androgen deprivation and androgen sensitivity. And there's many reasons for that you all know about related to mutations and overexpression of the androgen receptor and so on. And just one piece of preclinical evidence supporting that, these are two versions of LNCAP, one of which is bicalutamide resistant. At the same concentration of androgens, one cell line is suppressed, and there's lots of data that high levels of androgen can actually induce cell cycle arrest and inhibit prostate cancer growth, and the other one is maximally stimulated. So at one concentration, a low concentration, you have maximal inhibition in one and stimulation in another variant. And so you can imagine, this is a simplified model, 3 cell types. You have the stem cells. Stem cells are known to be androgen insensitive. They don't express the androgen receptor. They give rise, through a complex process, to androgen-sensitive epithelial cells and cancer cells. And then you've got a third type, which are partially insensitive. So these are the ones that must be present if you get a better outcome with very low levels of testosterone, which is what we saw in that data I just showed you. So it kind of stands to reason that you have, it's obviously simplified, but you have these 3 different types of cells with varying levels of androgen sensitivity. So you have your hormone-naive patient who's got a mix of cells. You drive the testosterone down hard below 0.7, and you wipe out everything but the stem cells, because the sensitive cells undergo apoptosis, so do the partially insensitive cells, because they respond to that very low level of testosterone. You're left with a largely, then the patient stops treatment, the testosterone comes up, the prostate cancer cells repopulate, mostly androgen sensitive. In contrast, you don't drive the testosterone that low. Let's say you only drive it down to 50 or 1.7. You're left with the red partially insensitive cells. They repopulate when testosterone recovers, and what you have is a more androgen-insensitive population at the same time point. And then, of course, due to survival mechanisms, you get adaptation and selection, and you end up with hormone resistance, but it takes longer. So this is a simple model that actually is supported by preclinical data that just can kind of integrate these two apparently contradictory observations. And the implication is, when you use intermittent therapy, you need to hit the patient hard during the on-treatment interval. You want this story, you don't want this story. We haven't looked at the intermittent arm of that trial to see if those patients also did better if they had low testosterone during the on-treatment interval. That's our next project. So to conclude and to break for beer and dinner, long awaited, I would say intermittent therapy has become the standard of care for most patients with biochemical recurrence. It should be. You need to monitor the testosterone and change therapy, either switch to a different drug, add an anti-androgen, do something to aggressively induce androgen deprivation during the on-treatment interval. There's a lot of unanswered questions in this area for the younger people here who are interested in research questions, all kinds of clinical trials still to do in the intermittent therapy story, including the optimal duration, timing, how much quality of life benefit is debatable, combined androgen blockade, 5 ARIs. This whole story about the testosterone level, I think, still needs to be sorted out, particularly in the intermittent therapy story, and the rate of testosterone recovery and what that signifies is also really unknown. Thank you very much.
Dr. Klotz, thank you very much. Any question? One question, or have it over there. Rob?
Hi, yeah, it's a wonderful talk. Was there a cost-effectiveness analysis with your trial? Because obviously if it's non-inferior, to get used instead of standard care, there's got to be some advantage.
We didn't do it, but it has been done. I mean, there's a significant cost reduction with intermittent therapy, absolutely, but not as part of this study, but that's certainly part of the appeal. One more thing, the patients in the PR7 trial were on therapy 27% of the time. So the cost reduction in terms of drug was about 3/4, which is pretty substantial.